Good morning. This is Patty Tuttle, Clinical Care Coordination Manager for TPMG. Today we're going to review how to work the Humana Gap Report. If you have worked the Anthem report in the past, this is not too much different. It will be easy for you to grasp, and if you haven't worked it before, it's still pretty easy. First, we'll go into the one-all drop box, and we will go to Humana, and then we will go to Humana Gap Info. As you can see, there are several documents there. There is a document called Key, Humana Basic Definitions, High-Risk Medications, GAPS 101 Humana, and again, the GAP Report Goal. There is also some information on statins, DMARDs, osteomeds, and ACE and ARBs. First, I'd like to give an overview of what GAPs are and why it's important for us to work our GAP reports. GAPs are simply tests that insurance companies want the patients to have done periodically to make sure that they remain in the best health state possible. They might be BMIs, might be colorectal cancer exam, could be breast cancer screening, which is a mammogram, etc. And again, if you're familiar with Anthem, we are also in a shared savings program with Humana. We don't have quite as many patients with Humana as we do with Anthem, but we're growing. With shared saving programs, the first hurdle is the insurance company looks at the whole panel of patients, averages the HCC score, and with that, they come up with a total amount of money that they feel we should be able to take care of all of those patients in the panel for a year. The first hurdle is getting under that amount. So as with Anthem, there are things that we do to get under that amount of money. Again, care coordination calls the patients discharging from the hospital, reviews their discharge information, and by hospital I mean Mary Immaculate, Bon Secours rather, Riverside Hospitals, and Centera. Those are the hospitals we get daily reports on. We review their discharge instructions, medication teaching. We make sure they have a follow-up appointment with either the PCP, specialist, or both, depending on why they were in the hospital. We call the folks that have gone to the ER unnecessarily because it wasn't an emergency, and we recommend where they could get care in the future that would be more appropriate. As a group, TPMG encourages generic medication use and sometimes brand formulary as well with some of the companies. We recommend that they get their imaging or tests that are needed at places that provide excellent care and are at moderate or low cost. This is something that we all work on together to get under the amount of money that we need to qualify for shared savings. Once we get under that amount, the next thing is how we scored on our gaps for that company. And that determines how much shared savings we are able to earn. The Humana Gap report comes only quarterly. So we receive that report 4 times a year. It's important, even after the due date, that you continue to close gaps. So by the time we get the next report, you will have many more gaps closed. One thing that's a little different with the Humana gap report is that with Humana, a few of the gaps are different from Anthem. Also, as the gaps are received in quarterly increments, we can make an extra bonus if we close a large percent of them in the first quarter, as well as the second quarter, third quarter. So the earlier in the year that we're able to close those gaps, the more opportunity we have for shared savings. Another thing that's different with Humana is it starts January 1st and it ends December 31st. And all gaps that will be due in that year open up January 1st. So even if a patient had, for instance, a fecal occult blood test in December of 2018, come January 1, that gap pops right back open because fecal occult blood tests are good for 1 year. So we closed it in the year of 2018. It pops back open January 1st of 2019 for the 2019 year. So that's a little different, takes a little getting used to. But everything that's going to open in 2019 opens January 1st. You can go ahead and close it. They will go ahead and pay for it. So let's first look at what are the gaps for Humana. Let's go to Humana Definitions Basic. Oops. Okay. Here's another difference with Humana gaps. Humana allows 3 gaps to be closed by patients verbally reporting to the physician that they have had the test done and the date it was done. The physician in turn must note it at an office visit for it to be counted. Here's how that would work. Breast cancer screening may be member reported. It would be good in the year of 2019 from October 1st of 2017 through December 31st of 2019. It would need to be within that time frame to close the gap. Let's say I come in to see the doctor and he says, "Oh, Patty, you're due for a mammogram." And I said, "No, doctor, I just had one on April 1st. That could be noted in my chart under histories. And when that office note is printed, it will have that information on it. That office note can be sent into Humana to close the gap until my mammogram report is officially in the chart at TPMG. We still want you to get the reports, but if the patient reports that a mammogram was done, colorectal cancer screening, or diabetic eye exam, they can self-report it and it will close the gap as long as it is in the office visit note for that office visit and it's within the time frame that it should be. So breast cancer screening is the first gap. It is good for 27 months for Humana. Adult BMI assessment is another gap. We would need to include the weight, the date, and the BMI. To qualify for gap closure, it has to be within the year 2018 or 2019. But we will need, of course, the height to calculate the BMI. Colorectal cancer screening can be closed by a fecal occult blood test in 2019, because that's only good for a year, a flexible sigmoidoscopy between 1/1/15 and 12/31/19, that's good for 5 years, a colonoscopy between 1/1/2010 and 12/31/19, that's good for 10 years, or a Cologuard between 1/1/17 and 12/31/19. That's good for 3 years. For our patients that think they do not want a colonoscopy, usually they will agree to a Cologuard or a fecal occult blood test. We would like for you to close it any way that the gap can be closed. The advantage of the Cologuard is it's good for 3 years, where the fecal occult is good for 1, but again, close it any way that you can. Diabetic eye exams. This isn't as complicated as it can be made out to be. And here's how this goes. If the patient has a diabetic eye exam, dilated eye exam, retinal eye exam, sometimes it's termed different ways. If retinopathy is found, the patient would be positive for retinopathy, meaning they have some type of retinopathy. The type does not matter. The exam is good for 1 year. If a patient has retinopathy, they want them to get their diabetic eye exam annually. If a patient has the diabetic eye exam and it's negative for retinopathy, meaning there is no retinopathy to be found at that time, then the exam is good for 2 years. Look to be certain that it is a diabetic eye exam or retinal eye exam, because a regular vision screening will not close this gap. So look for that name. Look for it to say whether they're positive or negative for retinopathy, because the date that it's a diabetic eye exam and that it's positive or negative for retinopathy are all the things that are needed to close that gap. Again, that is a measure that can be self-reported, but we still want you to get the results and put them in the chart as soon as possible. Diabetes care, blood sugar controlled. This is a little more complicated with Humana than it is with Anthem. With Humana, it has to be the most recent hemoglobin A1C, and it must be under 9. It has to be for the year 2019. So if a patient comes in the office in January and has hemoglobin A1C done, and the result is 6, and we send Humana the result because the gap stays open until they get the result, then that would close the gap. If the patient comes back in May and it's 9.1, the gap comes back open. It has to be the most recent one, and it has to be less than 9. So this could be a hemoglobin A1C that's received at TPMG, that's done at TPMG. It could be one done while the patient was in the hospital. It could be done at endocrinology. So we have to do our due diligence and make sure that it's the very last hemoglobin A1C done for the current period, and that it is less than 9. If the result is above 9, still put what the result is. Just know that it's not going to close the gap, but there's not anything we can do about that at the time. Diabetes care, medical attention for nephropathy. There are a number of things that can close this gap. A nephropathy screening, testing on all diabetic members in 2019. Again, this is one that is annual. If it's done even in December of 2018, it opens back up January 1st. So a number of things can close the gap. It could be time, spot, or 24-hour urine for microalbumin, a 24-hour urine for total protein. What I see most often is urine for microalbumin creatinine ratio. It can be a random urine for protein, creatinine. What I see second most is if the patient is on an ACE or ARB in 2019, that will automatically close the gap. So I look in the chart, and I would suggest you look in the chart. It's an easy way to close these gaps early. And if the patient is on an ACE or an ARB and it's been filled in 2019, put that information in the block. It will close the gap, and it will close it early. Any urine macroalbumin for 2019, if the patient received attention for nephropathy in 2019, if they had a nephrologist consult in 2019, or a renal transplant any date, all of those things will close this gap. And we'll talk about that a little more when I show you what the gap report looks like. Osteoporosis management. This is a gap that I work from my end of things, but I want you to be aware of it. Humana would like for women between the ages of 67 and 85 who have a fracture. They would like for the women to have a bone mineral density test or DEXA scan within 6 months after the fracture, unless they have had one in 24 months prior to the fracture. So we're looking for the latest DEXA scan, the latest bone mineral density. If after that test is done, it's indicative of osteopenia or osteoporosis, then they would like them placed on a biphosphonate to help prevent further bone deterioration. So they can't just be put on over-the-counter vitamin D and calcium, okay? This is something prescription. It's stronger. It would work better. What I usually do is I take this list of patients that has broken bones, and I will send something to the office manager or the physician, letting them know the guideline and asking if they will set up bone mineral density DEXA scan before a certain deadline. If the patient has had one within the past 24 months, again, that would close the gap. So that's what I'm looking for the osteoporosis management. Anti-rheumatic drug for rheumatoid arthritis. This is called the DMARD gap. This one I also work personally, but I want you to be aware of it. DMARDs are drugs that slow the progression of rheumatoid arthritis. So this gap is just for patients diagnosed with rheumatoid arthritis. And what they're asking for is that all of these patients be assessed for DMARD treatment. Okay? So of the list of patients that appear, the first thing I do is see if we have the diagnosis of rheumatoid arthritis. If we do not, I will send a note to the physician asking if the patient has that diagnosis. If the physician says no, I send a form to the physician to sign stating they do not have that diagnosis. And I send that to Humana. If they do have that diagnosis, then we ask the physician to send them to a rheumatologist to eval and treat for DMARD therapy, unless this has already happened. And one of the three things will happen. They'll either be put on a DMARD, or the rheumatologist will say they really don't have rheumatoid arthritis, or the patient will refuse the therapy. And sometimes they've tried it in the past and they just can't tolerate it. The exclusions to this are pregnancy or HIV positive or doesn't have rheumatoid arthritis. So you may hear from me on that, but I usually hide a few of these gaps on the gap report and work them myself. Here's another gap that is generally hidden, but again, you need to be aware. It's care for older adults, and it's a three-part. It counts for three gaps. The first part is medication review. They want to see that medication review has been done by the physician at least annually. The second part is functional status assessment, at least annually. And the third part is a pain screening at least annually. If the physician or the nurse practitioner does an annual well visit, all three of those gaps close because they're all included in the annual well visit. Next, we get scored on something that's called plan all-cause readmissions. And what they look for are 30-day readmissions where people have been in the hospital and then been admitted again within a 30-day period. Of course, they don't like to see that, so we try to keep our folks out of the hospital, and we try to keep them from being readmitted, even if they went in the first time for one reason, say for instance, congestive heart failure, and then within 30 days they broke a hip and were admitted. It still counts against us, even if it's not for the same reason. High-risk medication. I have a list I'm going to show you of what Humana believes are high-risk medications for members 65 and older. And what they do is they recommend some alternatives. I just would like for you to make sure the physicians have the list. Of course, the physicians will make the decision on what they feel is best for the patient and what drug they want the patient on. We are scored on this by claims only. There's nothing we can do other than just making sure the physicians have that list. And in the One All drop box Humana folder, you'll see high-risk medications. And if you could just periodically make sure your physicians have a copy of this, that's all we ask. This is the Humana key. It's found in the same location, the One All Humana drop box. It's pretty much the same key as we use for Anthem. There is one big difference. Humana can assign us patients. We're in a Humana Medicare Advantage program. They can assign us patients. So we cannot use never seen or not seen in 30 months. It could be a new patient. So we have to reach out to the patient and try to get them in to become established at your office. So one of three things will happen here. They'll either make an appointment and become established, which is great, that's what we want. They'll say to you, I already have a physician, I don't want to come to your office. And if that's the case, please ask them to call member services on the back of their Humana insurance card and have their PCP of choice changed. That is the only thing that takes them off our gaps. They have to call Humana and ask that that be changed. So if you speak with a patient under those circumstances, please let me know, and I will try to follow up on it and make sure that it is removed. It usually takes a whole quarter to get a patient off, but I'll follow up on it. If you tell me the patient said they don't want to see us, they have another physician. Sometimes folks will ignore your phone calls indefinitely. So what I'd like for you to do is to keep calling at least 3 times. Please call And if you cannot get them, send a letter. And if they still do not respond within a reasonable time period, and by that I would say, a month, 2 months, let me know then, and I will try to get Humana to take them off the report. Again, it usually takes about a quarter. Give them a little bit of time, because sometimes people are on vacation or they're just really busy and they don't respond right away. So I don't want, to get a call saying, I've called them 3 times this week, I want them off my gap report. It's not quite that easy. But do reach out as soon as you see them on your gap report, or you get them on a patient list that we provide, because you don't want to be dealing with this at the end of the year with a group of patients, because then their expenses will still be on us if Humana has them assigned to a TPMG physician. If the patient has expired, you can let me know. And there are a few physicians within TPMG who are not taking new Humana patients. If they receive patients they have never seen on their gap report, I do need to know that. Angela Walker sends something out a couple times a year where the physicians can choose if they would like to take new Humana patients or not, and we go by that until she sends the next one out. So it's important, if you get new patients and you're on the list that says you're not taking new patients, that you let me know. In the same location, there's something called statins, DMARDs, osteomeds, ASARBs. It's about 3 pages long. It has common osteoporosis medications on it. It has common DMARD medications on it. As you're looking through charts, it might be helpful. In addition to that, it has listed ACE and ARBs. And where this comes into play is we also get scored on whether our patients who are diabetic are receiving medications, statins for instance, of high intensity or moderate intensity. So here are the dosages that they would be on to close the gap. This is something we'll be focusing on this year. As you can see, sometimes patients are on the medication but at a lower dose, and this will not close the gap. We will touch further on this as we look at the gap report for Humana. Next, in the same location, there is GAPS 101 Humana, last revision February of 2019. It is pretty much the same way we work the Anthem report. Oops. So if you have worked that in the past, it's pretty much the same. We'll look first under alerts to see if a letter has been sent. That's where you'll find that information if care coordination has sent a letter. Secondly, we look under appointments to see if the patient already has an appointment scheduled to close that particular gap. Next, we do quickly check on the EPM side to see if the patient has been terminated. We'll check on both sides. We don't want to contact a patient who has been terminated. Next, we'll look at the physician, make sure it is a TPMG physician. If there's any confusion there, if you notify me, I'll go into the Humana system and see who the patient's assigned to, because whoever Humana says they're assigned to is who is going to be held accountable. So if they're no longer ours, we do need to have the patient call and change their PCP of record. Again, if the patient is not in the EHR and your office is taking new Humana patients, If you do not have the contact information, contact me and I will look it up in the Humana system and provide it to you so that you can make contact. Most often, Dr. Sharp or myself will send out new patient lists to the sites to call and get these patients in, and they will have the phone number and the contact information. These will usually go out long before we get a gap report. So if your office is taking new patients, please don't put never seen on the report. That means you need to reach out and get them in. Step 6, we'll look at, again, problems and diagnoses. Does the diagnosis make sense? And we have the same situation with Humana as we did with Anthem. If anyone in the healthcare system, be it TPMG, a hospital, another physician's office, has diagnosed this patient with diabetes, until that diagnosis is not used for 24 months, they're going to come up needing all those gaps on the gap report. Sometime in the past, that might have been used to get coverage or payment for certain labs, but that's the repercussions of that. The next thing we would look under is categories. If something is done by a non-TPMG provider, I'm looking to see if it's there, and you would look to see if it was there. Diabetic eye exams, I'm finding under consults. Of course, mammograms would be found under radiology. If I'm looking for lab work, and first I would look within TPMG, and if I don't see it there, I'd look under categories. There would be an entry for labs. I would check there. And if I don't see it there, I could look under consults, and I may see endocrinology, and it is most often going to be there on the endocrinologist note. So first, again, I would look at TPMG, and you know that hemoglobin A1C means hemoglobin A1C. Urine protein screening is keyword being urine, okay? So there are other ways to close that gap. That is the most common way I see it closed. If you see persistent monitoring for ACE and ARB, digoxin, or diuretic, they're all looking for the same thing. They're looking for a potassium and a BUN or creatinine. Each gap should have an entry made each month by the person working the gap. So if a letter has not been sent and it's a new gap and you would like a letter sent, you can put L in the grid for needs letter sent and highlight the grid box yellow along with the patient's name box. Okay, so you would highlight the whole thing yellow if you want a letter sent. If a letter has already been sent, you'll need to call the patient and see if you can go ahead and assist in scheduling the appointment. If you schedule it yourself, put S, the date you scheduled it, the date the appointment is, and your initials. If you called and spoke with the patient, or you spoke with the patient in the office, put called and the date you spoke to the patient. Please try to use refused sparingly, as we only want to use it for a true refusal. If a patient says, I'm not getting that ever, that's a refusal. And still, that's usually for a colonoscopy. I'd still try to talk them into getting the Cologuard or the fecal occult blood test. When studies are conducted from non-TPMG locations or by non-TPMG providers, it's important to document the information under the Histories tab in the EHR. Once this is done, scan the document into the category. Here's a clip of how to do this. Create a new encounter, click Template, Click on SOAP Note. Click on Chart Update. Next, adding historical information to a patient's chart, you would go to Histories, scroll down to Diagnostic Studies, and click Add. Please fill out all areas highlighted in yellow. Here are examples of the mammogram, the colon closure, and the diabetic eye exam, colon cancer closure. Adding historical information to a patient's chart. After filling in the highlighted areas, click Add to Grid and OK. Click Save at the top left corner, and now this is part of the patient's chart histories. Don't forget to scan the patient's chart, scan the report into the patient's chart in categories. If the report is already there and you want to add the information to histories, this is how you can look at both of those things at the same time so that you can correctly copy information under histories. Open the report that you need to add to histories and make sure this is next to the SOAP note. So as you can see, Report, SOAP note. Right-click on the second tab opened and select New Vertical Tab Group from the drop-down box. Then it will show both reports side by side so you can correctly copy the data into the patient's record under historical. If you have any difficulties, feel free to call me at 757-232-8829. I don't want this to be difficult. I'll be happy to walk you through it. Don't waste time. Don't spend a half hour trying to figure out one gap. Just call me and I'll help you walk through it. So this is what a gap report looks like when it comes. It comes directly from Humana. And I'm going to hide the upper portion so we've got more screen room we can look at for a minute. So it will have to the left the Humana card ID. I remove that and I make that a place where you can free text whatever your key information is. If you want to make a note saying you called the patient on this date, or the patient has an appointment on such and such date, that's where you would write that. With the Humana Gap report, you only fill out the yellow blanks, just the yellow blanks. So if there's a white blank, you do not need to fill it out. What I do want to show you, though, is some of the drop-down boxes. This is only going to let you put a service date in that will close the gap. So if you put the wrong date, it's not going to accept it. It has to be the BMI between 1/1/17 and 12. No, this is last year's. Between 1/1/18 and 12/31/19. I'm just showing you this as an example. It is not a current gap report. For this gap, colorectal cancer screening, it's going to ask you which of these was done. Was it a colonoscopy, a flexible sigmoidoscopy, fecal occult blood test, total colectomy, colorectal cancer diagnosis, a CT colonography, or a Cologuard? So let's say, for instance, you pick colonoscopy. When you go to put the date in, it's going to tell you the date range for all of these, whichever one you pick. And if the answer is not in that date range, it's not going to accept it. This block here is for member reported. That is only if the patient comes in and says, yes, I had that done. Here's the date I had it done. That is just until you get a copy of the report. But if that is, again, put in under the historical information, It will show up on office visit notes that are done anytime after that, and that can be accepted as closure until you get the report. This scrolls over. Breast cancer screening. The mammogram date will close the gap. If the patient is a bilateral mastectomy, they want the date of that. Unilateral left, the date. Unilateral right, the date. Member reported. Okay? The same thing goes for member reported. It must be in an office visit note. It must be placed under histories for it to be counted, and then you still need to get the report as soon as you can. Okay, this is one that I told you that I work. OMW base event date is going to be the date of the fracture. This will be the medication prescribed date. Then I would need to list it as well as the dose and the units and the route. If the patient is not in, if the test results are not indicative of osteopenia or osteoporosis, then I just put the date of the test, which is here. Again, it's only going to accept the dates that are applicable to close the gap. DMARD therapy, I would have to put the date, the drug, the dose, the units, and the route. Hemoglobin A1C, and because you fill that in once in the quarter doesn't mean you're done, because they could have, a hemoglobin A1C done again. So put the most current date and the most current result, whether or not it closes the gap. This is not something that can be member reported. They accidentally put that on the gap report last year, but hemoglobin A1C cannot be self-reported. Diabetic eye exam. For this gap, they want all of this information. They want the date of the exam. They want to know if it was member reported. They want to know, is it negative for retinopathy? Yes. That means it's good for 2 years. Is it negative retinopathy and they have retinopathy? Then the answer is no. Okay? It's kind of backwards the way it's asked, but what they're asking is, are they negative for retinopathy? Yes or no? They want to know the specialist name. They want to know the specialist type. They want to know the city the specialist is in. They want to know the state the specialist is in. They want all that information on each one. By specialist type, your choices are going to be in the drop-down box. Ophthalmologist, eye care specialist, or optician. If you don't know, just put eye care specialist if it doesn't say on the report. Optometrist, ophthalmology, optometrist, ophthalmologist, or eye care specialist. Okay, nephropathy. Let's see. If they visited a nephrologist, they want the visit date. If they had a renal transplant, that will close it. Medical attention would be if they were diagnosed in 2019 with acute renal failure, albuminuria, chronic kidney disease, chronic renal failure, diabetic nephropathy, or they're on dialysis, end-stage renal disease. All those things would be medical attention for nephropathy. Okay? They would all close the gap. And the date. The macroalbumin date, if it was done, would close it. Albumin testing, 24-hour albumin or protein, random urine for protein, creatinine ratio, spot urine for albumin or protein, timed urine for albumin or protein, and what I see most often, urine for albumin creatinine ratio, and the date. If they're taking an ACE or an ARB, that would close the gap report, and we would put the date of the fill. And again, just if they're yellow, those are the ones that are the gaps. So we spoke of this one I usually hide. Dr. Sharp or myself usually looks at it. Again, if they have an AWV for that year, it closes the pain assessment, med review, and functional status, all three. Medication reconciliation post-discharge is something we're also scored on. So the way this comes to me is a list of hospitalization dates here. Maybe they've been hospitalized 2 or 3 times. All the dates are going to come up there. And they want to know, after the patient discharged from the hospital, if their meds have been reconciled within 30 days. So it's very important if they come in to do a hospital follow-up that their meds are reconciled, because we're getting scored on that. Statin therapy for patients with cardiovascular disease. I believe we touched on that earlier. Statin therapy for diabetic patients. This is statin therapy for patients with cardiovascular disease. And what they're looking for is what the prescription is. Remember the list that showed the moderate and high intensity statins? So they want to know if it's moderate or high intensity. That's where that list is helpful. The dose, the unit, and the route. And the dose has to be high enough to close the gap. And I think we barely missed getting a 5 on this year. For 2 or 3, we're on the drugs, but that dose was a little less than what the insurance company requires to close the gap. So that's the Humana gaps. When a gap report comes in, I send an email to the office manager asking her to forward it to the gap doers. It will say your Humana gap report is in your Dropbox Humana 2019 folder and ready to be worked. It will have the due date on it and any additional information you need. Please read that entire email, as I will often give you new information in it that you will need to successfully work your gap report. And remember, the goal is to close the gaps. We want as many closed as possible each quarter. Again, if you have questions, certainly feel free to call me at 757-788-3072.